This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, this is a patient with non-dilating pupil. Looks to be a rigid pupil, and in this case I'm going to use the BHEX device, and in this case I'm not expecting any zonular weakness, and the nucleus also seems to be of moderate density and ideal for phacoemulsification, and I don't expect any further problem. So BHEX should be fine for this case. So let's begin. The surgery is being done under topical anesthesia with a little bit of intracameral lignocaine. The two side ports are made. The endocapsule is stained with trypan blue. The 2.8mm incision is created, and now is the time to place the BHEX device. The first thing to always do is to just place the BHEX on the surface of the iris. I usually would like to place these notches from this order. So usually I use the right side port to place the opposite two pairs of notches, then switch hands. So the globe is stabilized with the second instrument. In this case, I'm using the Banaji eye lock. The forceps has become a little bit crooked. Nevertheless, I could grasp the notch and glide it under the iris so that the two pairs of the notches can engage the pupillary margin. The beauty of BHEX device is its simplicity. It is so simple and quick to use, no hassles at all. The hands are switched, and the last pairs of notches are now being engaged. So you just have to rotate the eyeball just a bit so that you can visualize these notches, and then pull it centrally, and there we go. So all the notches are now holding down the pupil. It's really quick and fast, and the standout feature of BHEX is it's so thin and it's so gentle on the pupil margin that you hardly notice any sphincter tear at all on the next post-op day. I'm refilling the chamber with OVD, and time to perform the rhexis. So in this case, I'm going to use the forceps to perform the rhexis. The endocapsule is punctured, the flap is raised, and I'm going to perform the rhexis. So I'm going to size my rhexis, and the pupil will act as a template for me for sizing the rhexis. The pupil would be around 5.5mm with the BHEX device, and it acts like an excellent template to size my rhexis. So now we have an adequately sized rhexis. Time to perform hydrodissection. The OVD is burped out a little bit to begin with, then the hydrodissection cannula is placed under the capsule and a little bit of fluid is injected. I'm just trying to decompress the nucleus from the opposite quadrant, just to nudge it around to see that it is free. OVD is replaced into the eye, just to firm up the eye before attempting to rotate the nucleus. The nucleus rotation is confirmed. Time to emulsify. The initial superficial epinucleus and cortex is aspirated out. Time to perform the direct chop. Tip is buried into the substance of the nucleus. Using just the longitudinal energy, chopper goes down vertically down, and then there's a lateral separation maneuver. The fragments are broken down into multiple small fragments. So we have got around 6 smaller fragments, and now each of them would be emulsified. Now using the torsional energy. The plane of emulsification is critical. I always prefer to have it at the level of the rhexis margin or the iris surface. We don't want to emulsify anywhere in the antechamber. So this ensures that the mechanical trauma to the corneal endothelium is minimized. These pupil expansion devices have had a great impact in the modern cataract surgery era. They have enhanced safety considerably and hence made the outcomes predictable even in these complex case scenarios. Of course, in many of the situations, we can still go ahead and do surgery without using any of these devices, but you never know what will the underlying coexisting pathology. Some of the patients could have an underlying zonular weakness, which we could have missed preoperatively. So if we have used these pupil expansion devices, in the event of any such hidden surprises, we can still manage it quite safely because the visualization will be excellent, and that's the key for a successful and safe surgery. The cortex is aspirated. Time to place in the lens. OVD is injected into the bag, and the planned lens is now being placed into the capsule bag. So usually I prefer to remove the ring immediately after putting the IOL under the cover of OVD. The lens is placed into the bag, and now it's time to remove the BHEX device. I think the hallmark of the BHEX device is the ease at which we can disinsert and remove this device compared to any other pupil expansion device. So I'm going to use the micro forceps from the side port, and in a single movement we can disengage all the notches. And since it's a uniplanar design, we can directly pull it out of the eye without the fear of any of the notches getting entangled either in the iris or in the wound. So that's the unique feature and beauty of this device. In my experience, this has been the easiest to implant and pull it out compared to any other pupil-based expansion device. OVD both in front and behind the lens is aspirated out. The wounds are hydrated, and that's it, the case is done. Thank you for watching and hope you found this helpful.